Department of Neurosurgery LSUHSC New Orleans. Normal pressure hydrocephalus. Wally Dradwin. Department of Neurosurgery LSUHSC New Orleans. Learning aims: understand the typical clinical and radiological features of normal pressure hydrocephalus and how to differentiate it from other diseases in the differential diagnosis. Understand the current standards for the diagnosis and treatment of NPH. Review complications with shunting. Review and management of slit ventricle syndrome. History: NPH was first described by S. Hakim and Adams in 1965. Their reports were based on pneumoencephalography. Pointed out that it is often difficult to differentiate NPH from cerebral atrophy, still an issue today. Described classic triad of dementia, urinary incontinence, gait disturbance, pneumoencephalography. First introduced by Walter Dandy in 1919. Successively injecting small volumes of air via lumbar puncture and then removing small volumes of cerebrospinal fluid with the patient sitting upright and the head flexed. This method is no longer used. Presentation usually greater than 60 years of age. Triad: not pathognomonic, vascular dementia can present same way. Gait. Usually first symptom to show up: wide-based gait, shuffling, unsteady on turning. Feel glued to the floor. Dementia. Mostly memory problems. Bradiphrenia, slowness of thoughts. Urinary incontinence. Types of NPH. Primary, idiopathic. NPH is distinguished from secondary NPH, which develops secondary to subarachnoid hemorrhage, 23%, meningitis, 4.5%, and traumatic brain injury, 12.5%. A common feature of infant SNPH is that neither involves any obstruction to the flow of CSF within the ventricular system of the brain. Primarily a disease of the elderly. SNPH can occur in all ages. Diagnostic studies. No test or radiologic study is pathognomonic for NPH. CT or MRI. Disproportionate widening of the ventricles in comparison to the cerebral sulci, inner and outer CSF spaces. Lumbar puncture. Shows normal opening pressure, OP, should be less than 180 mm H2O. Response to single LP or serial LP has good predictive value. Patients whose OP is greater than 100 have better response to shunting. Continuous CSF pressure monitoring. Patients with normal OP may have LP peaks of greater than 270 mm H2O and recurrent B waves. AMP 10 to 11 mm Hg lasts 32 minutes. Diagnostic studies count. Ambulatory lumbar drainage. A 5-day trial is recommended, mean time to improvement, 3 days. Send CSF cell count and culture daily. CT and MRI. Communicating hydrocephalus. Findings that correlate with good response. Transependymal flow, may resolve with shunting. Compression of convexity sulci. Rounding of the frontal horns. Diagnostic studies count. Other imaging modalities to assess cerebral blood flow and metabolism or of CSF dynamics, PET, SPECT, scintigraphy, CSF biomarkers, and newer functional MRI techniques, so far play no role in routine clinical evaluation. The convexity near the vertex, red arrow, and the medial cisterns, green arrow, are widened, a finding consistent with brain atrophy. Callosal angle, blue line, angle greater than 90 degrees is typical of brain atrophy. Tight convexity, red circle, typical findings of NPH. Callosal angle, blue line, an angle less than 90 degrees is typical of NPH, right image. Symmetrical transependymal flow, blue arrows, suggests NPH. 75% of patients with NPH also have Alzheimer's or vascular dementia. Findings that make NPH less likely. Asymmetrical findings. Cortical deficits, for example, aphasia, apraxia. Paresis. Progressive dementia without gait. Disturbance. Lack of progression of symptoms. Treatment. The standard treatment of NPH is the implantation of a ventriculoperitoneal (VP) shunt. Lumbar peritoneal shunts have been used, but they tend to overshunt. Medium pressure valve, closing pressure 65 to 90 mm H20, to minimize the risk of subdural hematomas. Follow patients clinically and with CT for 6 to 12 months. Complications. 35% of VP shunts are associated with complications. Complications, shunt malfunction. Most common complication 40% of procedures. Most commonly caused by simple obstruction. Debris, fibrosis, parenchymal occlusion of catheter, choroid plexus obstruction of the proximal catheter, first 2 years after placement in general. Signs and symptoms of malfunctioning shunt. Headache. Irritability. Seizures. Vomiting. Lethargy. Gait problems, ataxia. Neck pain, back pain. Papilledema. Blurred vision. Blurred vision. Behavioral changes. Sun-setting eyes, infants and young children. Field cut. Blindness, complications, obstruction of peritoneal catheter. May be more likely with distal slit openings, slit valves, due to occlusion by omentum or by trapping debris from the shunt system. Biperitoneal cyst, or pseudocyst. Usually seen with infection, may also be due to reaction to talc from surgical gloves. Could be urine from rupture of over-descended bladder in patients with neurogenic bladder. Fluid can be aspirated percutaneously and analyzed for BUN and creatinine, which should be absent in CSF. Severe peritoneal adhesions which decrease surface area for CSF resorption. Malposition of catheter tip, at time of surgery, for example in preperitoneal. Complications, infection. Second most common complication 2 to 30% of procedures. Increased risk in children under 1 year of age. Most common organisms. Coagulase negative staph species, Staph epidermidis. Staph aureus. Enterococcus. E. coli. Pseudomonas. Signs and symptoms infected shunt. Shunt malfunction. Fever, erythema, cellulitis, wound infection around shunt. Nausea, vomiting. Lethargy, irritability. Headache. Abdominal pain. Diarrhea. Peritonitis. Feeding problems, young ones, slit ventricles. Totally collapsed lateral ventricles seen on CT of 3 to 80% of patients after shunting. Most asymptomatic. Slit ventricle syndrome. Overdrainage of CSF leads to collapse of ventricles, blocking fenestrations in proximal catheter, leading to increased ICP. Found in less than 12%. Intermittent headaches unrelated to posture, often with NN, drowsiness, irritability and impaired mentation. Signs may include 6th cranial nerve palsy, slit ventricles treatment. Asymptomatic. Prophylactic upgrading to a higher pressure valve or insertion of an anti-siphon device has largely been abandoned. Slit ventricle syndrome. If total shunt malfunction is the cause, then shunt revision is indicated. For intermittent occlusion, treatment options include 1. If symptoms occur early, initial expectant management, most spontaneously resolve. 2. Revision of the proximal shunt. This may be difficult due to the small size of the ventricles. Attempt to follow existing tract and place longer tubing or leave old catheter in place and insert new shunt. 3. Patients may respond to either of the following interventions because the slight ventricular enlargement elevates the ependyma off of the inlet ports. 4. Subtemporal decompression. Sometimes with dural incision. This results in dilatation of the temporal horns. 5. Third ventriculostomy. Complications: other subdural hematomas or hygroma, shunt infection. Higher risk with low-pressure valve and older patients. Usually accompanied by headache, most resolve spontaneously or remain stable. 1/3 require evacuation and tying off of shunt. Risk may be reduced by gradual mobilization post-op. Shunt infection. Intraparenchymal hemorrhage in the brain. Seizures. Delayed complications include shunt obstruction or disconnection. Radiographic studies shunt series, head CT. Plain radiographs of skull, neck, chest, abdomen. Used to detect disconnections, kinks, and migration of catheters. Proximal and distal catheters are radiopaque, reservoirs are radiolucent. Head CT demonstrates location of proximal catheter tip and size of ventricles. Comparison to prior study is critical. Radionucleotide clearance study. Radionucleotide is injected into shunt reservoir and observed as it flows proximally and distally. Ultrasound. For children with open fontanelle. Further diagnostic studies. Pumping the shunt reservoir. Assesses proximal and distal shunt function. Tapping the shunt. Assess shunt function and diagnoses shunt infection. Outcomes. Symptoms usually improve in this order: incontinence, then gait disturbance, and lastly dementia. Predictors for good outcome. Clinical presence of the classic triad. Also 77% of patients with gait disturbance as the primary symptom improved with shunting. Patients with dementia and no gait disturbance rarely respond to shunting. LP, op greater than 100 mm H20. Isotope cisternogram, typical NPH pattern. Continuous CSF pressure recording, pressure 180 mm H20 or frequent Lundberg B waves. CT or MRI, large ventricles with flattened sulci. Symptoms have been present for short period of time. Patients with suspected coexisting Alzheimer's disease AD may still improve with VP shunts, thus AD should not exclude these patients from shunting. Some responders may subsequently deteriorate. Shunt malfunction and subdural collections must be ruled out before ascribing this to the natural course of the condition. Question 1. What are the cardinal symptoms of idiopathic normal pressure hydrocephalus, inf. A. Apathy, tremor, and rigidity. B. Reduced muscle tone, urinary and fecal retention, and dementia. C. Gait impairment, incontinence, and dementia. D. Gait impairment, tremor, and akinesia. E. Difficulty initiating gait, affect incontinence, organic brain syndrome. Question 2. What constellation of changes in imaging studies, CT, MRI, definitively establishes the diagnosis of NPH? A. Narrow cisterns near the vertex and a callosal angle less than 90 degrees. B. Enlarged insular cisterns and inner CSF spaces. C. Enlarged insular cisterns and narrow cisterns near the vertex. D. A callosal angle less than 90 degrees and enlarged inner CSF spaces. E. There is no such constellation of changes. Question 3. What percentage of patients with INF also have vascular dementia or Alzheimer's disease? A 15%. B 30%. C 45%. D 60%. E 75%. Question 4. True or false? The lack of gait disturbance and presence of dementia makes patient less likely to benefit from shunting.